Hello, my name is Dr. Leo Hsu. I'm the Medical Director of St. Charles County Ambulance District, as well as for many of the fire protection agencies here in St. Charles County. I would like to take a few moments today to talk to you about treatment for cardiac arrest. Last year, I discussed the possibility for implementing a pit crew model for when we encounter the sudden cardiac arrest patient. After discussion and months of research, we decided to move forward with this idea. During this research, we were also introduced to a concept known as Cardiocerebral Resuscitation, or CCR. The pit crew model is really modeled after the pit crews for NASCAR. Each member of the pit crew has a defined role to ensure efficiency and effectiveness. The cornerstone of CCR is high-quality, minimally interrupted chest compressions to maximize blood flow to the brain. Places that have implemented the pit crew model in CCR have shown dramatic increase in survival rates and neurological recovery. I believe this innovative approach will translate to improved patient outcomes and increase survival to discharge rates. This will only solidify our reputation as a leader in cutting-edge cardiac care. This video and associated materials are the result of this innovative approach. Thank you for your daily efforts in outstanding patient care.
When fire district personnel are the first to arrive on the scene of a cardiac arrest, fire right begins compressions while fire left bares the chest. During the first round of 200 compressions, fire lead inserts an oropharyngeal or nasopharyngeal airway and applies a non-rebreather mask. Fire left applies and operates the AED.
Attach defib pads to patient's bare chest. Shock advised. Press flashing shock button.
Everybody clear? All clear?
Shock delivered. Start CPR.
For the second round of compressions, fire left will assume the role of compressor. This helps to prevent rescuer fatigue.
Good compression.
Upon the arrival of EMS, medic left assumes the role of team leader until the arrival of an EMS battalion chief. When EMS providers are the first to arrive on the scene of a cardiac arrest, medic right will begin compressions while medic left bares the chest. Next, medic left applies defibrillator pads. Medic left also inserts an OPA or NPA, applies an end-tidal CO2 cannula, and provides 15 liters per minute of oxygen by non-rebreather mask. Quickly, medic left analyzes the patient's heart rhythm and defibrillates as indicated.
Charged, everybody clear?
After delivering the first shock, medic left assumes the role of compressor from medic right. It is imperative that rescuers take turns performing compressions with each round in order to prevent fatigue and subsequently poor compressions.
Med check.
Ready.
I'm going to give 1 milligram epi 1 in 10,000 IV push.
Any contraindications?
None.
What's the volume?
10 cc's.
Clear. Give
All
it.
right. I'm going to give 1 milligram epi IV push.
All right, we're coming up on 2 minutes. Analyzing the rhythm still looks V-fib. Let's go ahead and charge. Charged. Everybody clear. Clear. Shock.
Immediately following the second shock, medic right takes over compressions. Medic left provides the next dose of epinephrine after completing the medication administration cross-check.
10 seconds. Showing V-fib on the monitor. I'm going to go ahead and charge for defibrillation. Charged. Everybody clear. You're clear. I'm clear. Shocking. Resuming CPR.
Moving ahead, immediately following the third round of compressions, medic left directs the application of the auto pulse. An end-tidal CO2 adapter must also be applied. Continuing resuscitation efforts, the crew should administer amiodarone as indicated, and, if torsades is present, magnesium sulfate should be considered. When EMS and fire personnel arrive together on the scene of a cardiac arrest, each rescuer has a specific and limited role which must be performed with optimal proficiency.
Okay, patient's pulseless anatomy to start compressions. Go ahead and cut the shirt.
Fire right begins compressions while fire left bears the chest. Medic left applies defibrillator pads, and fire lead applies an airway adjunct, an end-tidal CO2 cannula, and a non-rebreather mask. Medic right establishes IO access and prepares epinephrine, which will be administered during the second round.
Seconds, still seeing V-fib. I'm going to go ahead and charge. Charged. Everybody clear. Clear. Shot. Do CPR.
Med check.
Med check. Ready.
I'm going to give 1 milligram of epi IV push. 1 in 10,000.
Any contraindications?
None.
What's the volume?
10 cc's.
Clear. Give
All
it.
right. I'm going to give 1 milligram epi IV push. In.
Charged. Everybody clear. Clear. Shot.
And after completing the third round, rescuers apply the auto pulse. An in-tidal CO2 adapter must also be applied. Continuing resuscitation efforts. The crew should administer amiodarone as indicated, and, if torsades is present, magnesium sulfate should be considered. Monitor for signs of ROSC, which may include an abrupt, sustained increase in in-tidal CO2. If signs of gastric distension are present, consider inserting a nasogastric tube. Finally, if after a total of 30 minutes ROSC has not been achieved, consider terminating efforts to resuscitate the patient.